And I'd like us to welcome the presenter for today. Her name is Dr. Cindy Farley, midwife and professor emeritus from Georgetown University in the United States. And she will now introduce the 10th annual Georgetown Student Cafe at the VIDM. She'll introduce the presenters for this session, and this session is on management of Ankyloglossia in infants. Welcome, and Sydney, welcome to join to this session.
Thank you so much, Carolyn and Jane in the background there for the introduction and for your facilitation of our talk. It's management of Ankyloglossia in infants. I have been moderating the Georgetown VIDM Student Cafe for 10 years now in what began as an initiative to encourage student participation. I recommend to other midwifery educators to consider supporting their students in this wonderful opportunity. Next slide, please. I am author and editor of 2 midwifery textbooks that sell in over 28 countries worldwide, and I do donate my royalties to various midwifery initiatives. Next slide, please. Hi, I'm Cindy Farley. I'm a professor emeritus at Georgetown University in their midwifery and women's health nurse practitioner programs. I live in a small village in the Midwest area of the United States, and I've been a midwife for over 40 years. In my teaching, I encourage students to explore the evidence base supporting and shaping midwifery care. My students, Chastity, Burchuk, and Katie Hartzog, did an excellent job on their class presentation, and we wanted to share this information with you. Next slide, please. Here are the topics that our students have presented over the last 9 years. Hoya Saxa to our Georgetown students, faculty, and alumni. Hoya Saxa is a Latin phrase meaning what rocks. And on this day, all over the world, midwives rock. We have in our audience Katie Daly, who is a professor at Georgetown University and who is poised to continue the annual VIDM Georgetown Student Cafe into the next decade. Thanks, Dr. Daly, for coming. Next slide, please. Our objectives for this presentation on Ankyloglossia, and if you find that hard to pronounce, just say tongue tie, are as follows. Appreciate the role of the midwife in assessment of the newborn and of breastfeeding. Review common signs and symptoms of Ankyloglossia and the practice and evidence regarding treatment. We will ask you at different points in the presentation to type in the chat pod to share any experiences you have with Ankyloglossia. Next slide, please. This presentation ties into the VIDM conference theme this year, that of making connections. The connections midwives make with the people they serve during pregnancy and childbirth continue into the postpartum and breastfeeding periods and include the newborn. Parents often turn to the connection that they have made with their midwife as a trusted authority. When concerns develop that are outside of normal variations, parents are reassured that their midwife can offer them both emotional support and tangible strategies. Midwives make connections in another way on behalf of the people they serve. They connect presenting signs and symptoms with root causes, leading to accurate diagnoses and appropriate care options. To do this, midwives need knowledge and skills and an attitude of lifelong learning. This presentation will provide you all with the latest evidence and information to carefully assess the newborn's oral structures and feeding behaviors. And so without further ado, I will now hand our presentation over to Chastity and Katie. Happy International Day of the Midwife. And next slide, please.
Hello, everyone. My name is Chastity Burchuk. I'm very excited to share with you all that I have now completed my program requirements for the Doctor of Nursing Practice degree in midwifery and women's health at Georgetown University. So I will be graduating in a short couple weeks on May 16th. I am originally from Hawaii. I now reside in Los Angeles, California with my husband and 3 children. I have been a labor and delivery nurse for the last 14 years with experiences in high-risk pregnancy care, postpartum, and newborn care. I've always loved what I've done as an L&D nurse. However, my heart was always with my patients and advocating for a more physiologic birthing experience. So therefore, I felt midwifery was a brighter calling for me. I'm very passionate about women's health and midwifery advocacy, as well as improving access to equitable and evidence-based care for our maternal and neonatal population we serve. My hopes is as soon as I join with my community in the birthing world, I would be part of their more holistic birthing story. And now I'd like to introduce my presentation partner, Katie Hartzog. Next slide, please.
Hi, everyone. Thank you so much for attending. My name is Katie, and I'm currently enrolled in the WHNP and Certified Nurse Midwife dual track program at Georgetown University with the hopes to graduate this summer. I currently live in Roanoke, Virginia, which is located right along the Blue Ridge Mountains. I have been an RN for about 8 years with a focus on progressive care and critical care. But have done a little bit of everything during my time as a travel nurse. Women's health and empowerment have always been important to me, which is why I decided to go back to school to pursue a master's as a WHNP and a CNM. Access to care is near and dear to my heart, especially living in a rural area with very limited access to birth care. I am also very passionate about empowering our patients and autonomy. I recently have been on the other side of things, giving birth to my first baby this past March. That was quite the experience, and it really solidified a lot for me when it came to women's healthcare. Next slide.
So we would like to start off with our case study. This is AC. She is a 35-year-old gravida 3 para 3 003, assigned female at birth at 39 weeks gestation. She had an uncomplicated spontaneous vaginal birth and is now 2 days postpartum. She had a baby boy who weighed 7 pounds 2 ounces. APGARs were 899 and a delayed cord clamping of 60 seconds. She had an intact perineum, QBL, which is quantitative blood loss, 250 cc's, and she plans to exclusively breastfeed with no formula. AC has a history of exclusively breastfeeding her 2 other children successfully for more than a year each, and she feels that she has a good grasp on how to latch and feed her baby well. On postpartum day 2, she presents with a painful right cracked and bleeding nipple. The latch score was a 5, and she states that after breastfeeding, she noticed a painful blister on her nipple that ruptured yesterday. Her baby has now lost 11% of his birth weight and has been told that she needs to supplement with formula. Next slide, please.
So what are some differential diagnoses that could explain what is happening in our case study? If anyone wants to throw some suggestions in the chat box. If anyone has any ideas what it could be going on with our baby? Insufficient latch, tongue tie. Yes. So insufficient latch, tongue tie. So let's see what's going on with this infant. Next slide.
So upon physical examination of the newborn, as you can see here on the picture on the left, it was a palpable lingual frenulum indicating a tongue tie or ankyloglossia. The lingual frenulum connects the underside of the tongue to the floor of the mouth. And according to a study by Cruz et al. In 2022, the overall prevalence of ankyloglossia among infants is 5% in the US. However, because there is no standardized or uniform diagnostic tool, the prevalence can range between 2% to 20%, depending on the classification tool used. And it's also noted that the prevalence of tongue ties are slightly higher among boys than girls, with a prevalence ratio of 1.34. And about 50% of infants with a diagnosis of tongue tie have difficulty breastfeeding. And there are several assessment tools, and these are some of them listed on the right, that are currently being used to determine the degree of the tongue tie. And these are widely known tools that are used clinically. And some of the tools measured the length of the tongue tie, the degree where it is attached to the tongue or the lower gums. And however, these tools have not been validated. Current best practice should indicate an objective standardized anatomic and functional assessment for tongue appearance and mobility, as well as latch, regardless of the grading system used. Next slide, please.
Okay. So where you see this baby now, is there anything else you would want to assess on this newborn? And then what are some potential consequences of having a tongue tie? If anyone has any ideas, you can throw them in the chat box. A connective tissue there. Latch score. Yes. I'd want to look at position and attachment. Yeah, definitely want to look at position and attachment. So yeah, like we touched on just briefly earlier, you would also want to do a breastfeeding assessment in person to utilize a latch score or an infant breastfeeding assessment tool. You want to see how the breastfeeding is going in person. And then potential consequences of a tongue tie. Like we touched on, poor latch, difficulty breastfeeding, maternal nipple pain. It can actually affect jawline and dentition a little bit later for these little kiddos. Speech may be affected later with limited range of motion for the tongue. It may be difficult to pronounce certain words. It can lead to a lisp. These infants can have some GERD issues and then obstructive sleep apnea later in life. And for this study, the tongue tie on this baby attaches to the anterior tip of the tongue, which is one of the more severe cases of a tongue tie. These ties are often noted alongside with a posterior tongue tie, which tend to be harder to visualize. The more severe ones can be easier to identify, but mild to moderate can sometimes be more difficult to evaluate. Just to note, a tongue tie with normal mobility is when the length of the frenulum is greater than or equal to 16 millimeters. Oftentimes in practice, despite the degree of tongue tie, if it's symptomatic, interventions are usually recommended. And again, those symptoms would be kind of what we're seeing here with the maternal nipple pain, the poor latch, and like poor milk transfer. Next slide.
So there are varying degrees of a tongue tie. From the top on the left picture, the tie is attached to the tip of the tongue. And the third picture down shows the attachment is at the mid tongue. And the last picture down below shows a more posterior tie. And there are other different ties we also have to assess for. The midline maxillary labial frenum, which is also called an upper lip tie, attaches the maxillary lip to the mucosa above the maxillary central incisors, which are the two front teeth. And this can also affect babies' breastfeeding due to the inability to properly flange the upper lip to obtain a proper latch, and can assess using the Stanford classification system. The thicker the lip tie is, it can affect the infant's future dentition. And this is one of the reasons why some people have a space between their two front teeth. There's also the buccal frenum, which is on the right, is basically a cheek tie. It attaches to the mucosa of the buccal region to the mucosa of the maxillary and mandibular ridges. If the tie is tight, it can limit certain movements of the lips and cheeks during eating, speaking, and even smiling. In infants, it can restrict the gape or opening of the mouth, which can affect latching on the breast, leading to breastfeeding difficulties. Next slide. And these are a couple of graphs that show you the number of inpatient newborn ankyloglossia diagnoses in the US by year. And the next one is the number of inpatient treatments, such as infant frenotomies that occur in the US by year. Next slide, please.
Okay, so when we look into some of the current literature on tongue ties, this first study is a quantitative analysis from Canada. Breastfeeding was assessed using a latch tool and by subjective questioning. Maternal nipple pain was assessed using a numeric rating scale, and mothers did receive breastfeeding counseling before and after a frenotomy. So this looked at nipple pain and breastfeeding changes after a frenotomy was performed. No complications were reported with the frenotomies. There was significant improvement in latch scores immediately post-frenotomy. There was also a significant decrease in median pain score immediately post-frenotomy, from a 3 on the left side, a 3.25 on the right side, to 0 bilaterally. There was also subjective improvement in breastfeeding, reported in 90% of the mothers immediately after the frenotomy and 83% of the mothers by day 14. So limitations with this study, it's a small sample size, and they only followed clients up to 14 days with a specific focus really on the first 48 hours. This next study was a prospective randomized trial in the US. It looked at the impacts of frenotomy on tongue ties. This was an interesting study because they actually used a bottle feeding system that was capable of objectively measuring tongue function. It was called the infant feeding solution. It was actually FDA approved to do this. And those that were randomized into the surgical intervention arm had the frenotomy right away. Those that were in the control arm waited 10 days and then had the frenotomy. And then they were all evaluated 10 days later. So those randomized in the control arm, the outcome measures were completed immediately prior to the frenotomy, which was 10 days after enrollment and another 10 days post-procedure. It is interesting in this study that all of the participants in the end ended up getting a frenotomy. It just depended on when. At the 10-day point, the interventional arm demonstrated statistically significant improvement in 11 objectively obtained feeding metrics, which meant like faster tongue speed, more rhythmic and coordinated sucking motions, and the tongue was more capable of adapting to varied feeding demands. There was significant improvement in breastfeeding self-efficacy in the interventional group, while there was still poor self-confidence persisting in the observational group before the frenotomy. Infant reflux symptoms improved in the interventional group and not in the control group. And nipple pain also persisted in the control group, but improved in the surgical cohort. Again, this is a small sample size. Bottle feeding was incorporated, so it's kind of hard to relate 100% to those exclusively breastfeeding. And eventually everyone got the intervention, which kind of created a shorter window of study. The third study is a prospective cohort study from Australia, and they look to determine the impact of using a laser to perform a frenotomy on infants. Traditionally, it's kind of used with surgical scissors. And then how that frenotomy impacted breastfeeding and GERD outcomes. They looked at 132 infants, and there was a few different kind of frenotomies performed. There was lip and tongue tie, there was lip only, there was buccal, or there was all three. All the infants had a post-op follow-up visit at 1 week, as well as 1 month follow-up online survey. And they used the breastfeeding self-efficacy scale and the infant gastroesophageal reflux questionnaire. The results did show a statistically significant improvement in both breastfeeding efficacy and GERD on those questionnaires at the 1 week and the 1 month follow-up. There was also a highly significant improvement when there was combo surgeries performed. There are some limitations. A lot of the information is self-reported data, and they only follow clients for a month. Next slide.
We also wanted to look into the trends from other countries. In Barcelona, a prospective cohort study was conducted to determine if frenotomies performed inpatient at 48 to 72 hours after birth will improve maternal pain and breastfeeding rates at discharge. The study included over 1,000 infants who were born at the hospital in 2018. In that group, 451 infants had a tongue tie. All tongue tie infants used the Hazel-Baker score of less than or equal to 8 and were offered a frenotomy. 29 families declined. They had what was left was 422 infants who had the surgery. It was found that 95.2% of infants improved their latch score. Maternal pain improved, but was not significant. And there was a significantly higher rate of exclusively breastfeeding among the tongue-tied infants who had the frenotomy at discharge compared to those who were not treated. The second study was an Irish longitudinal observation study, evaluated the mother's pain experiences with an infant who had a frenotomy. The observation period was from January to October of 2023, and it yielded 157 infants attending a publicly funded clinic. 96 infants had the frenectomy. About 101 families completed the baseline questionnaire. 34 did the follow-up questionnaire. It was revealed that 45% of the mothers brought their baby to the clinic for problems with latching, and 40% of them were due to nipple pain. The average reported pain during breastfeeding before the procedure was 2.53 on a pain score of 0 to 5, which is 5 as being the most painful. And after the procedure, mothers reported an improvement on pain with an average score of 1.47. Therefore suggesting a frenotomy can positively impact breastfeeding for both mom and baby. And our third study here is a prospective cohort study from Hong Kong. It evaluated breastfeeding outcomes after a frenotomy at a hospital-based lactation clinic over a 2-year observation period. 49 infants were referred for a frenotomy, and 36 actually had the procedure. Mothers were given a self-rated improvement questionnaire where 0 represents no improvement and 10 represents excellent improvement. At the 4-month follow-up, the mothers were interviewed by phone. And after the procedure, there was a greater improvement with sore nipples and latching. At 4 months, 80.6% of the frenotomy group were still breastfeeding versus the non-frenotomy group at 44.4%. Therefore, indicating that frenotomies do improve maternal nipple soreness and direct breastfeeding rates and duration. Next slide, please.
So there's one study that we looked at by done in the UK by the National Institute for Health and Care Research, published in July of 2023. And their goal was to dive deeper into the efficacy of frenotomy for tongue tie. They felt like the existing trials for frenotomy efficacy were small, underpowered, and were short term. And that it was hard to distinguish if the tongue tie itself was causing difficulties or if it was more of a lack of breastfeeding education and support. 169 infants 10 weeks and younger were enrolled in the study, and they randomly allocated groups to standard breastfeeding support groups or the support group that had a frenotomy intervention as well. The main thing that they were looking at was if mothers who were having difficulties with breastfeeding due to tongue ties were still breastfeeding at 3 months after these interventions. They found that there was no statistically significant difference in breastfeeding rates between those who underwent frenotomy and those who didn't. But what is interesting about this study is many of the participants in the control group went and had a frenotomy done before the 3-month mark because they had heard from other providers or family and friends that a frenotomy was the best option, despite the research not conclusively showing that. This obviously frustrated the researchers and made it harder for them to compile the data, but it's interesting because I think it speaks to kind of medicalization based on general ideas and beliefs, regardless of the amount of evidence presented. And what the study did find in terms of implications for practice was that mothers in both groups actually had higher rates of breastfeeding continuation and reported less pain when feeding at the 3-month mark, which kind of emphasize the importance of continued breastfeeding support no matter what throughout the postpartum period. As a side note, just complications of frenotomy are rare. In this study alone, they were observed about 1 in 50 babies, and the biggest issue was salivatory gland damage. Next slide.
So depending on the provider chosen to treat tongue ties, they may also recommend other supportive or alternative treatments to help aid in healing and improving oral motor skills in babies. And this includes our oral physical therapy. It introduces oral motor exercises that can be taught to the parent so they can implement it at least twice daily at home. Craniosacral therapy. So with birth, the compressive forces of during birth can result with putting pressure on the infant's nervous system, especially with the cranial nerves, controlling their suck, swallowing, jaw mobility, and the GI system. And craniosacral therapy is a gentle touch therapy which can help ease the tension in the infant's head and neck to promote a better latch and feeding, improving cranial mobility and function. Myofascial therapy is also a gentle touch therapy that helps stretch and strengthen the baby's head and neck. Post-frenotomy tongue stretching exercises. This is where parents are taught to lift the tongue or upper lip post-frenotomy for 1 to 2 seconds, about 3 to 4 times daily to prevent possible reattachment or regrowth of the frenulum. And osteopathic manipulation therapy treatments have been shown to be helpful with latching problems for breastfeeding. However, evidence did not relate those latching issues with tongue ties. Although these treatments may be recommended by a provider, they all do not have sufficient evidence and are not well studied and are often out-of-pocket costs for families. And these are things that we need to consider as part of the holistic plan of care for the infant if they do decide to go this route. Next slide, please.
So what can we do as midwives? One of the biggest things is the assessment. So a big thing is identification of the tongue tie and potentially possible appropriate referral. You can see on the Tabby tongue assessment tool on here. It's based off the Bristol tongue assessment tool. One thing I like about the Tabby is that they used midwives' input to create it and continue to utilize midwives throughout the auditing process of this tool. The goal of the tool was to create something more easy to read and something that could be easily translated to other languages. They found that midwives thought it was easy to use, and there was a 97% agreement between the Bristol tongue assessment tool and the Tabby tool. A score of 8 indicates normal tongue function, 6 or 7 is considered borderline, and 5 or below suggests an impairment of tongue function. As we know, selection of infants for frenotomy requires an additional breastfeeding assessment, but all the infants with a score of 4 or less in the audits using the Tabby tool had a frenotomy with parental consent. So it really helps to gauge severity, which can be the difference between non-invasive and invasive interventions. So some non-invasive things that we can do or encourage is if you score a baby and there's a mild tongue tie, there are some things that we can try before frenotomy. There's thought that if the tongue tie is thin, it can break or stretch over time. We can teach positions and breastfeeding techniques, chin adjustment to get a deeper latch, exercises that encourage tongue mobility and softening of breast before breastfeeding, things like that. We can also refer to lactation if needed. So can midwives perform frenotomies? I can only speak to what the research that I found on the United States is that the American College of Nurse Midwives have a position statement that looks at the expansion of midwifery practice and skills beyond basic core competencies, and frenotomies can fall within that. They can also fall in some places under the first assist regulations. Again, you know, for here in the United States, state by state regulations can come into play, but that's looking more on like a general scope of this. So yes, so short answer is yes, but definitely state to state regulations can differ, and it depends on training as well. Referrals, if we don't feel comfortable with more advanced breastfeeding support or don't have the training to perform a frenotomy, then we can always refer to our colleagues in the area. Next slide.
So we want to ask the audience, what types of providers can you refer your patient with ankyloglossia to in your area? Have you worked with any of them? So we have a midwife, health visitor in our trust in the UK who have been trained and run a frenotomy clinic each week. Wow, that's great that you have a frenotomy clinic. Lactation consultants can also help with the therapy of and learning how to breastfeed. Yes. Pediatric dentists, yes, definitely. Peds ENT, yes. And so these are great referrals and professionals that you can refer to. Another would be pediatricians who can do them as well. But a fun fact that I found in our research is that midwives can be trained to specialize in this training, and it's great that you have, there's clinics out there. Another fact that I found is that in the 16th century in Europe, midwives were actually the first ones to perform a frenotomy. What they did is they kept a fingernail long enough and sharp enough to stripe the tongue of all newborn babies. So that's a little bit of a history lesson for you guys. So just a food for thought. Next slide, please.
So do we need to treat tongue ties with frenotomy? So as we saw on previous slide, of the graphs, tongue-tie diagnosis rates are increasing, as are the rates of frenotomies. And as we have seen, tongue ties can be asymptomatic or have a wide variety of consequences, including difficulty breastfeeding. They can impact dentition, speech, and other social factors. Treatment often involves division of the band that provides better tongue mobility. Although it's like generally accepted to be very minor and a safe procedure, nothing is without risk, and there's still considerable debate about when and how to intervene. The data we have on breastfeeding effects mostly look at the short term and not the long term. Having a severe tongue tie can lead to other problems later in life, like speech impediments, lips, dental formation. It's less certain on the mild and moderate. And the efficacy and the cost effectiveness of the frenotomy is up for debate. Not to say that those with severe tongue ties don't need it. It's more about the mild to moderate. There's an interesting article written by a German pediatrician that spoke to the fact that breastfeeding issues are almost always multifaceted, and it's important that everything is being looked at and addressed, that we're not just jumping straight into frenotomies unless it's truly indicated. Selection of infants for frenotomy assessments and function and feeding assessments. We want to be looking at all aspects: breastfeeding, maternal structure, infant structure, tongue structure, using our assessment tools, clinical judgment. Is it a feeding problem? Is it an anatomy problem? Discussing it thoroughly with the parents as well. As always, we need to have good assessment skills, take into account everything the mother and the baby are experiencing, know the resources and the referrals in the area, and make the best informed decision and recommendation, taking into account all the risks and benefits and the client preferences as well. So really just taking in everything that you're seeing with your client before making a decision. Next slide. So with this, again, it's looking mostly at the United States. Living in the United States, there are many barriers that people face with getting timely quality health care. These are things we need to take into consideration when treating our clients with tongue ties. Access to care is going to be a big issue when it comes to all aspects of the tongue tie treatment. The ability to get an appointment or see a provider in a timely manner to diagnose a tongue tie. There can be really long appointment time waits. The later the frenotomy is performed, the greater risk for issues and for it not to help with breastfeeding. Having a quality provider in your area who performs a frenotomy can differ state to state. And you have to travel long distances to find a qualified provider. This can lead to transportation issues, missing work, and the lack of ability to follow up. Lack of lactation consultants in the area can also pose a lot of issues with long-term follow-up. The U.S. in general is not great with follow-up postpartum care, period. It feeds into a lack of support, and clients don't know who to reach out to. They internalize breastfeeding issues and think something is wrong with them, and then infants go untreated. Tongue tie is considered a procedure, a few different ways to perform a tongue tie, but the availability on how the tongue tie is performed can be dictated by insurance or by what's available to you. Insurance coverage in general can pose barriers depending on what is covered, and Medicaid can be very particular about what steps have to be taken before an invasive procedure is actually covered. Next slide.
So going back to our case study, and due to the fact that this baby caused his mother nipple pain, has not adequately breastfed with a poor latch, poor milk transfer, and having lost 11% of his body weight, a scoring of a 2 on the TABI assessment, it was recommended for the family to have a lingual frenotomy to be beneficial for the baby. With shared decision-making and informed consent, they consented for a frenotomy by surgical cut with scissors. Here you can see the before and after the frenotomy. Soon after the procedure, and with the help of the lactation consultant, the baby's latch score improved to a 9. 1 month later, the newborn was doing well, gained 2 pounds from his original birth weight, and the mother reports no more nipple pain while breastfeeding. Next slide, please. Here are our references. Next slide. And next slide. We have a long list of references. And next slide.
Yes, thank you, Chastity and Katie. Happy International Day of the Midwife to everyone, and thanks for your kind attention. I do want to read this message from our chat pod. It was from Kate, who had to leave early, but said, "Thank you for this presentation, really important issue. And as a midwife trained to perform frenotomy, I appreciate wider knowledge and discussion here." Thank you very much. So if anyone else in our audience is training or has trained to do a frenotomy, please let us know. And any other questions that you have.
Wow, thank you. Thank you, Sydney. Thank you, Chastity and Katie. Very, very informative, very thought-provoking. I've learned so much from this. And I want to believe the audience have some questions and comments, and they're coming in the chat box. I can see it's busy. But as we're reading that, the one question that struck me was, there's something that you said that caught my attention. Why boys than girls? Why more boys than girls? Any research on that?
Well, we haven't really delved into the deeper thought of that. It was a aspect that was reported in one of the studies that we had read about. It is an interesting fact there. That's something that definitely needs to be looked into further.
Okay.
Along
All
those
right.
same lines, Olivia in the chat box asks, did your research include any information regarding folic acid intake being associated with tongue tie?
I don't know about you, Katie, what you've researched on. I have not come across one that referred to folic acid supplements in pregnancy as an effect of tongue tie.
I didn't really come across that either. I will say that a lot of our research is mostly focused on like interventions for tongue tie and efficacy of that, not so much the cause of tongue tie, but it's very interesting. I would definitely be interested in looking more about that. But yeah, we were more focused on like the intervention part of it. Which type of frenotomies are performed the most? I honestly think the what I found, I think Chastity, I guess Chastity too, are like the simple tongue ties, the ones that are used like surgical scissors in office. I know laser is gaining more popularity though. I don't know if Chastity saw anything else.
From what I've seen as here in Los Angeles, the lasers have becoming more popular. One thought of it is that, you know, if there's no exercise or movement of the tongue post frenotomy, the possibility of the frenulum or the tongue tie growing back and reattaching is the thought. So in order to prevent that from happening, kind of keeping that movement of the tongue or the lip, whichever was treated, would help prevent it being reattached, and it would help also heal better, and also practice the lips and to flange more so that the latch would be better as well. The question is, do insurance cover laser? From what I've seen in my local area here in Los Angeles, I don't think it was covered. It was an out-of-pocket cost.
Same. Sometimes a more simple procedure like the in-office, like surgical scissor, like frenotomies were, but the laser and the more advanced ones were not, from what I've seen as well.
Okay. So thank you very much. Thank you for the feedback. We really appreciate, and I'm sure we've learned quite a bit. We're heading towards the tail end of this session. So if there are no more comments or questions, I think let's just, we'll need to end this session. So thank you very much for attending VIDM 2025.